Thank you very much. I want to thank Professor Tarantino who invited me here to be part of this wonderful event and to speak on this subject. When I got this topic from Professor Tarantino, I was in a dilemma whether to present it with a more extensive review of the literature or to present or to give you a presentation of our cases and methods that we use. I was in a dilemma because it is a relatively old topic. It is it is also a large topic with very extensive review of the literature, and I opted to present of our cases and examples, several our cases and examples in connection with all three parts of the topic, as my view as view of my clinic on this topic. When we talk about percutaneous management of liver collection, we primarily think about liver abscesses, unilocular and multiple localization, and liver cysts, simple and hepatitis malignancies, normal malignancies are not the subject of this topic. Firstly, I want to present several cases from our experience with the percutaneous management of liver abscesses. This is a classical case, two abscess collection in the right liver of the right liver lobe, 17-year-old boy, 2 weeks after appendectomy. We perform Percutaneos management, proper method we use to access abscess collection. Pus was evacuated as much as possible. After that, vigorous irrigation by antiseptics, iodine and saline 50 to 50, and this is a scar in the place of the abscess collection a few weeks later, and this is barely visible scar a few months later. Percutaneous management is especially important in the treatment of multiple liver abscesses, especially if they are located in both liver lobes, or if patient critically ill one suitable for surgical intervention and general anesthesia. This is multiple abscess collection. This is catheter in the abscess collection, and this is control examination a few weeks after patient was discharged from the hospital, the same regions of the liver without abscess collection. This is the evidence that percutaneous management is not too aggressive method. Here is patients from the previous slide with 6 catheters introduced simultaneously without general anesthesia and without any complication. According to the position of the insertion sites of the catheters, we can conclude that abscess collection were located in both liver lobes. Abscess collection in the right upper quadrant of the abdomen. They are very often associated with extensive surgical interventions in abdomen. In abdomen, this is large abscess collection in the right upper quadrant of the abdomen after total gastrectomy. Abscess collection in the right upper quadrant of the abdomen very often accompanied with pleural collection, such as pleural effusion or pleural empyema, and they are very often resistant to percutaneous management until pleural collection persists. This is This is situation when catheter was introduced by Rocker method into access collection. Drainage process went properly, accordingly, but access collection persisted until we introduced catheter into pleural collection and solved it, and after that, access collection in the right upper quadrant of the abdomen disappeared, and as you can see, liver and catheter in the right upper quadrant of the abdomen without any abscess collections. Other simple cysts, echinococcal cysts, are other liquid collection in the liver which are very often treated by percutaneous management. When it comes to simple liver cysts, percutaneous management is fairly simple. Catheter should be introduced into cyst cavity, and the content of the cyst should be evacuated as much as possible. Catheter should be kept in the cyst cavity until any content would be obtained, and this is scarred in the place of the cyst a few weeks later, and this is scarred in the same place a few months later. Treatment of echinococcal cysts is separate topic for today, but this treatment is a bit more complicated, and I want to take, I will just take a moment to show some interesting insights from our experience with the PAIR technique in treatment of echinococcal cysts. This is PAIR technique with the restoration of PAIR technique, multivesicular echinococcal cyst before, during, and immediately after its restoration by PAIR technique. 6 weeks after its restoration, a large abscess collection was formed in the place of the cyst, which was also treated by second percutaneous drainage, and this is a large scar in the place of the cyst after second intervention, which was smaller after 3 months and well visible after 9 months. These video clips show the beginning of the restoration multivesicular echinococcal cyst by a little modified PAIR technique, and this is the same cyst, CT images of the same cyst before, immediately after its restoration, and it is a view of the catheters which was introduced into cyst cavity next day after its restoration by PAIR technique. This is evidence that surgical treatment is not gold standard for the echinococcal cyst. This woman underwent 4 surgeries in 4 different countries. No Italy. Consequently ending up severely scarred. And yet, on control examination after 4 surgeries, ultrasound revealed a large liver echinococcal cyst with dotted cyst, which was confirmed that the echinococcal cyst was alive. This is scarred in the place of the echinococcal cyst after its restoration by PAIR technique, and this is control examination of the same liver without echinococcal cyst after its restoration by PAIR technique, and with a large defect in the liver tissue and the numerous new adhesions in the right upper quadrant of the abdomen after 4 surgeries. Percutaneous management can be performed as initial temporary or definitive management for symptomatic biliary fluid collection, such as percutaneous cholecystectomy, percutaneous biliary drainage due to obstructive jaundice, and treatment of complication after cholecystectomy. This is I was changing my presentation today because the program was updated that this topic should be presented by Dr. Restivo, but I include this slide, and this is presentation of percutaneous management of acute perforated calculose cholecystitis with the large abscess collection in right upper quadrant of the abdomen as definitive treatment. Biliary calculosis could be seen after partial evacuation of the pus and necrotic content. After evacuation of the pus was completed, vigorous irrigation by antiseptic was performed, and this is scar in the position of the gallbladder bed after 2 months, and this is scar after 1 year. This particular topic, it is known that surgical cholecystectomy is the first choice method for the treatment of cholecystical calculosis. But in elderly and critically ill patients with comorbid disease, emergency surgery can result with serious morbidity and high mortality, far higher than in elective settings. In the clinical settings, percutaneous cholecystectomy have been shown to be as alternative, life-saving life-saving method for them. As temporary or definitive, it is disputable. In the case of the biliary obstruction, we can perform biliary drainage in order to decompress biliary tract before or after surgery with endoscopic retrograde or nasobiliary drainage or by percutaneous approach. Percutaneous endoscopic retrograde cholangiopancreatography is accepted as diagnosis and treatment first-line modality in patients with jaundice secondary to biliary obstruction. Percutaneous approach should be performed as alternative management when the endoscopic approach is endoscopic intervention or reintervention fails. When we perform percutaneous biliary drainage, we use 5-frame catheters with tops with G or pigtail tops, and introduce them by under ultrasound control. This is situation a few days after introduction of the catheter, and intrahepatic biliary ducts were partially collapsed, or by 8 French catheters, we introduced them by plastic trocar method. Laparoscopic cholecystectomy is the first line therapy for the calculous cholecystitis as less traumatic, less painful, short hospital stay, short recovery time. But laparoscopic cholecystectomy carries increased risk of biliary tract injury following bile leakage or bleeding and formation, liquid collection in the gallbladder bed and the right upper quadrant of the abdomen, consequently, with consequences after infection and formation of abscesses as complication. This complication could be successfully treated by percutaneous management. This is large abscess collection after laparoscopic cholecystectomy, catheter in the abscess collection. Several days later, Aqueous collection was increased, was significantly increased. Several hyperhogenic shadows represented metal clips, which was used during laparoscopic cholecystectomy, and this is scar in place of the abscess a few weeks later. Pancreatic fluid collection can be associated with acute or chronic pancreatitis, pancreatic ulcer, or pancreatic trauma, but much often they are caused by acute pancreatitis. Acute pancreatitis is very complex disease, and despite of the existence of several clinical and radiological criteria for assessment of its severity, it takes to predict its subsequent course. It is also very difficult to predict whether acute fluid collection formed early at the stage of acute pancreatitis would be resolved spontaneously, or would it already reflect gross destruction of the pancreatic gland with subsequent poor clinical course. Acute pancreatitis, severe form of acute pancreatitis, acute necrotizing pancreatitis, acute infected necrotizing pancreatitis, can be associated with systemic complications such as multi-organ failure and sepsis, and local complications such as aqueous fluid collection, effective and sterile pancreatic and pancreatic necrosis, pancreatic pseudocysts, pancreatic abscesses, or all of pancreatic necrosis, which are defined according to the New Atlanta classification, and pancreatic fistulas. And this is evacuation of large acute fluid collection, during acute pancreatitis. Acute fluid collection can occur in about 40% early at the stage, both mild and severe acute pancreatitis as enzyme-rich pancreatic fluid collection. They resolve spontaneously in about 50% of cases, and intervention is usually not necessary. However, severe form of acute pancreatitis can cause systemic release of numerous cytokines and inflammatory mediators, leading to activation of inflammatory cells, fever, and multi-organ failure. In those clinical settings, the removal of the toxic mediators and inflammatory substances can ameliorate systemic consequences induced by acute pancreatitis. It can be performed by Percutaneos and by endoscopic approach. And it is evacuation of large acute fluid collection, which were associated with massive pancreatic and peripancreatic necrosis, which can seen after evacuation of liquid collection. After evacuation of liquid collection, this is in these clinical settings. We should remind the catheter in the pancreatic and peripancreatic necrosis in order to eliminate secondary liquid collection. This is massive pancreatic and peripancreatic necrosis in order to eliminate secondary fluid collection arising after destruction of the necrosis. This is a large acute fluid collection in acute pancreatitis with necrotic tissue at the back, but normal pancreatic tissue is not visible. This is catheter in the back evacuation of acute fluid collection surrounding with massive pancreatic and peripancreatic necrosis. This massive pancreatic and peripancreatic necrosis with secondary liquid collections formed behind of the top of the catheter, and for its elimination we should perform its aspiration or reposition of the top of the catheter, and sometimes we have to introduce a new catheter for examination. And this is patient control examination a few months after these patients discharged from the hospital. Pancreas is inhomogeneous, but the signs of the acute pancreatitis, such as acute fluid collection and pancreatic and peripancreatic necrosis, are disappearing. The appropriate treatment of acute necrotizing pancreatitis, especially infected necrotizing pancreatitis, is the subject of much debate. It is generally accepted that solid necrotic, non-vital infected tissue should be removed in order to control the sepsis. Earlier, it was performed by surgical method, by surgical necrosectomy, with all complications and risks which are associated with this method. Recently, minimal invasive, minimal non-surgical method using truly conservative and continuous catheter drainage method, percutaneous or endoscopic, included in this treatment. The area of the drainage method in the treatment of infected necrotizing pancreatitis, the pancreatitis is equivocal, and the result very diverse, very varies between studies. Several authors consider that drainage method are less effective in the treatment of infected pancreatic necrosis and in the removal of the necrotic debris. But other authors consider reported significantly better success rate, showing minimal invasive non-surgical method as effective treatment for infected necrotizing pancreatitis. It is true that in the beginning of the disease, solid necrotic tissues involve all pancreatic and peripancreatic regions, peripancreatic areas. In the beginning of disease, the removal of solid necrotic tissue is poor, but regardless of the catheter drainage methods, endoscopic or percutaneous, or even regardless of the catheter size that we use. But during the clinical course of the disease, a transition from the solid necrotic tissue to more liquid content and formation secondary liquid collection, and mixture of the liquid and necrotic debris leads to higher success rate for evacuation of necrotic masses from the necrotic cavities. This is situation 2 or 3 weeks after the beginning of the treatment, and normal pancreas surrounded by liquid collection and necrotic tissue, and catheter was kept into liquid collection, liquid pancreatic collection. And this is situation a few months after the patient was discharged from the hospital. Pancreas, appearance of the pancreas is practically normal, and this patient with severe form of acute pancreatitis, with the infected necrotizing pancreatitis, and with poor, which was in poor general condition, was solved by these minimal invasive non-surgical methods. Pancreatic percutaneous management can be performed in treatment of pancreatic cirrhosis, as I said, and effective with a low complicated rates, and relatively low recurrence rate, which can eliminate the need for surgery in majority of patients. Continuous percutaneous drainage is more effective than single-step needle aspiration or percolation because continuous percutaneous drainage, independently percutaneous or endoscopic, continuously eliminate the contents of the cyst or the pseudocyst, which was really pancreatic, and eliminates its lytic effect and leads to obliteration of the cyst and the obliteration of the communication between pseudocyst and the pancreatic duct. Pancreatic acid or pancreatic necrosis, very disputable topic for the treatment. Surgical treatment is generally accepted with all complications or and risk which are associated with this method. Recently, there is increased enthusiasm to perform minimally invasive drainage methods such as needle aspiration or continuous catheter drainage, endoscopic and percutaneous. This study is very diverse between radiological and surgical studies. And pancreatic fistula. Pancreatic fistula are linked to acute or chronic pancreatitis, pancreatic surgery, pancreatic trauma. The usual treatment of pancreatic fistulas are conservative or surgical when conservative treatment fails. Percutaneous treatment is relatively unusual. I presented this large retropancreatic abscess collection with two fistulas. These two fistulas after triple necrosectomy for necrotizing pancreatitis. Patient was admitted in our hospital for general collection condition with fever, with abdominal pain and presence of pus in the stool and by cutaneous periumbilical fistula. Ultrasound revealed large abscess collection in the retropancreatic regions. Catheter was introduced and pus was evacuated as much as possible. After that, contrast medium was confirmed the large abscess collection in the retroperitoneal space and two abscess collection, retroperitoneal cutaneous fistula and retroperitoneal sigmoidal fistula. And when we introduce antiseptic iodine into abscess collection, it appeared by cutaneous periumbilical fistula. We perform continuous drainage, vigorous irrigation by antiseptics, and proper administration of antibiotics. And after 6 weeks, this abscess collection disappeared and fistula closed. This is conclusion. Ultrasound plays important role of the biliary and the pancreatic fluid collection, but ultrasound is very modern method, and it wants to lead progressively towards modern methods such as Formula 1.
Congratulations for your lecture. How many time stay the stent when you drain pseudocyst?
It is individually, but I think that it is a good question. If we drain it pseudocystic short time, the recurrency is often. Then if we drain it a long time, generally we drain it pseudocyst until any content could be obtained through the catheter. But in some case cases drained for we couldn't get any content through the catheter, but after if we remain the catheter into cyst cavity, after a few days after we again could be obtained content of the cyst.
From the literature, we know that only infected fluid collection in acute pancreatic necrosis or acute pancreatitis and after these events, but it seems that you also drain non-infected fluid collection during in the acute phase. Is it true? Did you understand?
It is true. We have
which is the rationale for this, and then which sites of pseudocyst do you drain? Since probably if they are not infected, most of the others prefer not to touch it.
Yes. We have a rather long experience with the treatment of acute pancreatitis, and we treated many patients of acute pancreatitis with acute fluid collection or without fluid collection by conservative treatment. But I agree that some fluid collection should be treated by conservative treatment, by follow-up and proper intravenous hydration but in some clinical settings, in the cases of the gross destruction of the pancreatic gland due to impairment of the microcirculation of the pancreas, can develop massive pancreatic and peripancreatic necrosis. And in that clinical settings, activated enzyme-rich and protein-rich fluid collection, which was translocated into pancreatic or peripancreatic regions, should be removed in order to control the sepsis, in order to cardiovascular collapse and to prevent systemic consequences induced by acute pancreatitis. In the cases of pancreatic pseudocyst, I think that pancreatic pseudocyst should be treated only if they are symptomatic. But its recurrence depend of its communication between pancreatic ducts. And generally, if you drain it longer, success rate is better.
So you confirm you evacuate the debris even if there is no infection during the acute necrosis of the pancreas. This is rather in contrast with the opinion of most surgeons and most interventionalists, radiologists about this. Do you have any explanation of this difference in behavior, in approach? Do you think that your experience is sufficient to say that the evacuation of the debris, of the secretion of the pancreas actually improve the course of the disease?
Yes. I generally agree with you. But approach must be individually. But I think that approach should be step by step. In the beginning, only conservative. In the beginning, only conservative treatment. When only conservative treatment fails, we should be perform percutaneous or endoscopic drainage.
Large fluid collection, even
Yes.
if not infected, you think
Yes.
it's better to drain?
In the case of large fluid collection, I said that in 40% acute fluid collection can occur. 50 of them dissolve spontaneously, but we should decide, we should assess which is rest of 20% of the acute fluid collection which cannot resolve spontaneously and which should be treated.
We have a different experience regarding drainage of pancreatic collection. If we were asked by the surgeon to perform a drainage, at first we were just going to an aspiration with a very thin needle. If we had culture which was positive for bacteria, then we were allowed to do the drainage. Otherwise, in our hospital, we were not allowed to put any drainage in that collection. Moreover, if by CT or MRI we found the presence of necrotic material or blood clots, we were not allowed to do the drainage because we found a very high association of contamination with bacteria-resistant antibiotics, and we were unable to get rid of the inflammation and infection. Therefore, after we rewarded, we just did drainage in patients with culture-proved infected fluid collection without necrotic material in there. And we used the combination of both ultrasound, fluoroscopy, and CT guidance. Mainly if the collection are very large, to put very large catheters in there with very large bore diameters, so that more safe regarding the amount of path that we're going to take off. And we also use it always to cover the patient with antibiotics before, which were chosen according to the clinical history of the patient, the prior hospitalization, or if possible already known blood cultures in the same patients.
It is true that using percutaneous drainage, supplementation is possible. But in the case of long-term stay, acute fluid collection, which is pancreatic juice collection, pancreatic activation enzymes, superinfection is possible from the bacterial colonization from the digestive tract, from the colon also. But when it happened, superinfection during percutaneous drainage, we can sample of the infected content and to prescribe proper antibiotics according to the after analysis of the bacterial strain. In the cases of the bacterial spread from the colon, we also have a superinfection, but kind of the bacteria we don't.